Thank you very much to all the speakers. Anna Hansel from University of Leicester. So I'm actually a public health doctor by background, and thinking across this presentation and discussion, we have good evidence to act at a community level to prevent exposures to various sources of pollution. But I'm not sure that the evidence is as strong in a clinical setting and with individuals, with the type of interventions that we might use. So I think we highlighted in one of the guidelines was talking about an individual avoiding exposure to areas with high air pollution. But what we don't know is would interventions in their home to prevent the indoor air pollution from, say, cooking and other indoor sources, candles, incense burning, those sorts of things, would a air purifier help in reducing the risk of air pollution, of hypertension? So some studies have looked at that for asthma and COPD, but I don't know that there's evidence to look at cardiovascular impacts. So I think there's room for intervention studies to look at how we might intervene at an individual level in patients to see if that's actually going to be beneficial in terms of their long-term health. And my second comment is about environment, to think a bit wider about metal and chemical pollution, which I haven't seen mentioned this morning and I can't see on the programme. But we still have issues relating to lead and heavy metal exposure, and we have many thousands of chemicals that we're exposed to on a daily basis that we have very limited toxicological evidence on. So I think there's a big scope to investigate those further.
Who would like to comment?
Thank you. The comments are valid. I think for lead, at least Professor Stassen gave a lecture last year. Maybe he can, but I mean the metals and are very important. You know, the German government just now also yesterday released also issues to reduce this in water and is also nitrates, etc. So that's many aspects are public health issues with regard to the. I think we have to sit together to think about to providing evidence for any intervention, and start thinking about to do that at the individual level. There's also obviously there's the public health issue, which I think there's many aspects we agree on. But individually, I mean, there are nice mechanistic studies showing endothelial dysfunction if you have like air pollution, even indoor, I guess. Yeah, and we had also a lecture on this by Philip van der Born. He's an expert in this and doing studies on this. But we have to think about providing more evidence and do more research on this, I think. So. But these are more, you made very valid comments, I can't answer. But it's not only me, I'm not an expert actually in the environment, but I try to provide at least some response.
Thank you. Any more questions? I have two questions to Christian. Christian, first of all, congratulations again for covering such excellent way, such fascinating topic. And the first question is, listening to your talk, I was just thinking, what is the impact of nightlight exposure, excessive nightlife exposure, to development of various types of insomnia? This is the very first question. And the second question is, we know that the mean duration of sleep globally has been shortened, particularly in the United States, to 1.5 2 hours per day. And again, what is the impact of nightlight, contribution of nightlight exposure to this phenomenon?
Well, thank you very much for these difficult questions, which I probably cannot answer. Well, first of all, yeah, night light exposure has been increasing, as I showed in my presentation, And I think in terms of insomnia, I'm not sure whether you know there is CBTI, so it's cognitive behavioral therapy for insomnia, which is a very good, it's the first line treatment, at least in Switzerland. I think, in my opinion, it's much better than sleeping pills. And we are also trying to implement circadian light aspects there. So we call it CBTI plus chronotherapy. And one of these recommendations is also light hygiene, because a lot of people don't know that light can affect your sleep. You know, when you complain about your sleep, it's probably your bed partner snoring and noise and too high temperature, but nobody thinks about light, or not so. So we have to educate people and these patients. And yes, indeed, when you see people with for adolescents and teenagers, they're gaming, you know, into the night, and they sometimes develop a circadian sleep-wake disorder, especially a delayed sleep-wake. So we have an entire unit just with more than 30 patients between 16 and 25 who are there how to learn not to game and how to learn when to game, you know, and also about light. So light influences your sleep-wake behavior. And the second question was shortening of sleep duration. It's a bit controversial, by the way, in the meantime, because when you go to populations without electricity, there are still some in Africa and especially my colleague in Argentina. And sleep duration is not longer than in our Western world. So they also sleep between 6-7 hours because they go out. They have to, you know, they have to work and they have to. So it's a bit controversial whether we sleep less than 50 years ago. Even in Switzerland, we look at it. So there's a decrease of half an hour every decade, you know. But now it stabilizes, by the way. So there is a lot of stabilization. And what the impact on this is, I don't know. I cannot really. I just get probably more daytime sleepiness. But on the other hand, you can also say that probably we just cope with it, and we can. I'm not saying that we should sleep short, but sleep duration is one thing, you know. It's not the most important thing in my view. It's also how intense you can sleep, how efficient you can sleep. So you can have a 6-hour sleep or 7-hour sleep, which is as good or even better than a 10-hour sleep, which is just too fragmented. So sleep duration is not the only output quality measure. Sorry to be so long.
There is.
In fact, I have two questions. The first one is for Kay, Professor Kay Sayama. Do you really think that it is a good idea to let the treatment of blood pressure be guided by the temperature? I think what is important is the blood pressure, and the few millimeters mercury difference that you see associated with seasonality, in my mind, cannot make a big effect. So I think my personal opinion is it is already so difficult to make patients adherent, and then if you start changing treatment, I would not be in favor of that. And then for the other speaker, the question is, there was a mention of tapering in the very elderly antihypertensive treatment. I'm against that. You know, hazard ratios, relative risk, is high at middle age, and you have to treat a lot of people to prevent an event. But in the very elderly, the relative risk is small, but the absolute risk is very, very high. So the benefit of treating hypertension in the very elderly is much higher than in the middle-aged people. So I would be very careful in tapering. Well, you might taper treatment if there are symptoms, but also the very elderly and the frail patients, they have a right to be treated for hypertension.
Well, thank you very much for the question. The first issue is to my understanding is whether the impact of such as fine control of regarding season variation is effective or not, right? If so, yes, this would be the other aspect in clinical practice that based on the strict blood pressure control based on home blood pressure, that even especially in summertime, their blood pressure fell down excessively to show some indeed adverse effect. But as I show in the slide, the summer, midnight summer nocturnal blood pressure would be higher than the usual. Therefore, it would be greatly affected by room temperature and might be the air pollution in the room. And therefore, at least the continual blood pressure assessment is yes, essential to change, to treat the patient very finely, and not just to follow the current guidelines. We clinicians should see the patient's exact conditions as well as blood pressure. I suppose so.
The second question was about tapering or stopping antihypertensive treatment in the very elderly.
Maybe I can begin with this to give at least my opinion. I am also a bit against, let's say, systematic tapering. Now I think some people have been over-treated from start, probably due to white coat effect or other, and then with age it becomes more dangerous, and when you do a BPM it's quite low. And also some older people, they tend to develop a kind of dysautonomy with or without orthostatic hypotension, and then you are obliged to decrease. But otherwise, we are indeed fighting sometimes geriatricians who think that when you are old, you should decrease, and I'm also against this, but I'm sure other people may have other opinion.
I think it really depends what you mean by decreasing, because of course you can decrease because you're afraid of hypotension because it's very hot. This is one situation. But globally in the elderly now there is this trend of deprescription. And deprescriptions does not mean that you stop drugs that just because you stop drugs, but you stop unnecessary drugs. You stop drugs that do not really provide benefits to the patients. And for example, a lot of sleeping pills, antidepressant, blah, 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 which actually induce the falls much more than antihypertensive. Maybe not necessary, and actually prevent a good adherence to the necessary drugs. So I think the topics are a little bit wider than just that, but what you said is just about when it's hot. In Switzerland, they made also a very nice study in home for elderly. The difference if you have air conditioned or not air conditioned. And the interesting thing in elderly home, if you have air conditions, you have almost no changes in blood pressure, and you have no excessive dipping, so you don't have to change anything because people are in good conditions.
I think the point of Professor Stassen was not about transitory decreasing, but again, the benefits of treatment of hypertension in very old people, and this is, I think I would agree. But
yes, maybe if I make a comment as well. I mean, we should, and if you talk to geriatricians and geriatric medicine colleagues, they don't speak about age, they speak about biological age. Chronological age basically much meaning, it's all about biological age, and we do have these people, and that's why I showed also the studies from the trial, very fit elderly to the other end of the spectrum, nursing home, residents, dementia, etc., etc. And there we should, I think we can really start prescribing drugs, etc., and which we do, by the way, in clinical routine for years, and now we have some evidence at least. But that's completely a different story when you compare this with very fit old people, 85, something like this. You often see them walking into your office, and for sure you will do all kinds of drugs and treatments, and well, I'm a cardiologist, and TAVIs, etc., etc. So it's all about biological age.
Thank you, and we have time for one more question. From the audience? No.
Actually, it's not a question, it's rather a comment to the first question, which was raised here about the air purifiers and the mitigation of the problem of air quality, especially in indoor air quality. So actually, it is something what is definitely very needed to be developed. So we have to look for the health benefits related to the usage of the air purifiers, because what we have is wide evidence of that the air purifiers, they improve the air quality inside the rooms, different kind of buildings, but there are unequivocal results of the health studies regarding the using of the air purifiers. Yes, so we have the studies where the results show that there are health benefits, and the studies that do not confirm these health benefits. So this is something what I think is that there is a very wide area to develop this problem. Yeah, so thank you.
Question.
Maybe a very short question in the end. What about the light now here in this room? To me, it seems to be dark, but I don't know what's then the expert opinion.
Sorry, the light in here. Well, I can guess. You know, you can. It depends, of course, where you are measuring. So we are measuring at the eye level in our ambulatory study. But I would, well, maybe we are around 120 lux, 100 lux, which is, well, it's good to see the slides, right? So there is always a trade-off between vision and your biological clock, of course. Even when we do shift working studies, consulting, you know, what kind of light for there. There is always the trade-off. But from a chronobiological perspective, it's too low, because right now we would need strong light, 10,000 lux, especially in the morning. That's how we treat patients with seasonal depression, for instance. Yeah, but we can go and have a break now outside.
That's no, but yeah, that's.
No, I just leave it like this because we want to see the slides, right? But I think so, right?
Thank you for putting this up, because this was exactly what I wanted to say. I think if there are no more burning questions, we can close the very successful first session and have coffee and daylight, hopefully, outside. And we meet again at 11:25, right? Okay, thank you.
Yes, coffee outside.